Bismillah ar-Rahman ar-Rahim. Now we will start the last session, breast surgery. Professor Dr. Walid Nahas, Assistant Professor of Surgical Oncology, he will give us a presentation on fibroadenoma versus Lodge's tumor. Okay.
Mr. Chairman, my professors, my colleagues, thank you very much for the invitation as a speaker for this conference. And I think my talk today is very important because we face fibroadenoma more common than breast cancer.
دكتور وليد احنا بس نعتذر عن change of schedule عشان دكتور وليد مرتبط بسفر دلوقتي المنصورة. فبعتذر للدكتور رضا والسبيكر الثانيين ان هو هيسافر وهنبتدي بيه وبعد كده هنمشي السكادول العادي دكتور رضا بيه وبعد كده دكتور عمر وهكذا.
شكرا. Benign breast diseases represents a spectrum of disorders that come to clinical attention as imaging abnormality or as palpable lesions found on physical examinations. Fibroadenoma and phylloid tumors are fibroepithelial tumors of the breast. They are biphasic as they are neoplasms characterized by proliferation of both epithelial and stromal component. Fibroadenoma and phylloid tumor share some overlapping morphology, but significant difference in pathologic features and clinical behavior define various subsets of fibroepithelial tumors. Distinction between fibroadenoma and phylloid tumor is very, very important as fibroadenoma behave as a benign fashion while the biological behavior of phylloid tumor is unpredictable. Fibroadenoma are most commonly found in women between the ages between 15 and 35 years and the most common in adolescents, and 20% can be present as multiple bilaterally or in the same breast. Phylloid tumors account for less than 1% of all breast malignancies. The majority of phylloid tumors occur in women with the median age between 42 and 45 years. The high-grade tumors are more common in older patients. In men, phylloid tumor can occur in association with gynecomastia. As we know, the pathological types of fibroadenoma is 3 types, either simple fibroadenoma or juvenile fibroadenoma, and the difference in between in the amount of stromal proliferation. And the term complex fibroadenoma is a fibroadenoma contain other proliferative changes such as sclerosing adenosis, duct epithelial hyperplasia, epithelial calcification, or papillary apocrine changes. And this type is very, very important as this can predispose to malignancy. The term giant fibroadenoma is any fibroadenoma more than 5 centimeters. The pathology of fibroadenoma is nodular and encapsulated, included in the breast. The epithelial proliferation appears in a single terminal duct union and describe duct-like spaces surrounded by a fibroblastic stroma. And according to the amount of stromal proliferation, there are 2 types: the intracanalicular fibroadenoma, in which the stroma proliferate and push the duct-like slit-like, and the pericanalicular fibroadenoma, in which the duct is still rounded in shape. Although the fibroadenoma classified originally as non-proliferative lesions, the fibroadenoma are now considered proliferative breast disease. The risk of subsequent breast cancer is slightly elevated only if the fibroadenoma is complex, if there is adjacent proliferative disease, or if there is a family history of breast cancer. For the majority of women with simple fibroadenomas, there is no increased risk of developing breast cancer. The pathology of phylloid tumors is grossly the phylloid tumors may be indistinguishable from fibroadenoma. They are round to oval multinodular masses with a grayish-white appearance that resemble the head of a cauliflower. The phylloid tumors grow radially, creating a pseudocapsule through which tongue of stroma may protrude and grow into adjacent breast tissue. Necrosis and hemorrhage can occur in large tumors, as we can see in this picture. The histological types of fibroadenoma is 3 types: benign, borderline, or malignant, based on the assessment of 4 features: the degree of stromal cellular atypia, mitotic activity, infiltrated or circumscribed tumor margins, presence or absence of stromal overgrowth. The stromal elements are a key component in differentiating phylloid tumors from fibroadenoma and in differentiating a benign tumor from a malignant one. The clinical pictures of both phylloid tumors and fibroadenoma, sometimes we cannot differentiate between both clinically. The fibroadenoma appear rounded with distinct borders, easily moved, firm or rubbery. They are most frequently in the upper outer quadrant, but may occur in any quadrant, and painless. The phylloid tumors mostly have a smooth, multinodular, well-defined, firm mass that is mobile and painless. Tumor size is very variable, from small size to very large size, but the average between 4 to 7 centimeters. Shiny, stretched, and attenuated skin may be seen overlying large tumors, as we can see in the pictures, with huge phylloid tumors in which sometimes there is ulceration of the skin. Although palpable axillary lymph nodes can be palpated in phylloid tumors, but metastatic involvement of lymph node with phylloid tumor is very rare. Diagnostic evaluation. The diagnostic evaluation between fibroadenoma and phylloid tumor is challenging. The mammography, sometimes they appear the same, but as we know all, the mammography is not recommended above 30 or sometimes 35 years because the density of the breast and the appearance of fibroadenoma is always homogeneous and well circumscribed. The typical appearance of a phylloid tumor in mammography is a smooth, polylobulated mass resembling a fibroadenoma. Although imaging features of phylloid tumors can be suggestive of fibroadenoma, the large size and the history of rapid growth indicate otherwise, something else other than fibroadenoma. In this mammography, as we can see, the lobulation and the heterogeneity in the tumors indicates the presence of phylloid tumors, and there is some ultrasound pictures suggestive of the fibroadenoma, like halo sign, hump and dump sign. The ultrasonography, phylloid lesions are primary solid, hypoechoic, and well circumscribed on ultrasonography. Suspicious for a phylloid tumor rather than a fibroadenoma is always based on the clinical features such as large size, and presentation and rapid growth. But there is ultrasound criteria may indicate the phylloid tumor, like heterogeneity, hypoechoic mass with lobulations and irregular margins, and also the presence of cyst formation, but it is not constant in all cases. Compared to the fibroadenoma, which appears as circumscribed homogeneous oval hypoechoic masses with a smooth echogenic capsule, and this ultrasound picture suggestive of phylloid tumors. The MRI malignant phylloid tumors are seen as well as circumscribed tumors with regular wall, high signal intensity on T1 and low signal intensity on T2. Cystic changes may be seen as well. When a phylloid tumor has been diagnosed in a core biopsy, breast MRI may determine the extent of the disease and resectability. However, the routine use of breast MRI in surgical planning for phylloid tumors is controversial and not supported by data. The other diagnostic feature is the fine needle aspiration cytology. And fine needle is very accurate in diagnosis of fibroadenoma, but has been associated with a high false negative rate and low overall accuracy for the diagnosis of phylloid tumors. Some experts, however, advocate paying special attention to three major cytological features of fibromyxoid, fibroblastic pavement, and spindle cells of fibroblastic nature to improve the accuracy of fine needle. But until now, the fine needle aspiration cytology is not accurate in diagnosis of phylloid tumors. The core needle biopsy, additional features can help to distinguish phylloid tumors from fibroadenoma. Such features include increased cellularity, mitosis, stromal overgrowth, and fragmentations, but there is a false negative rate of about 20% for diagnosis of phylloid tumors by core biopsy. If the result of a core biopsy is indeterminate, an excisional biopsy is required. Additionally, core biopsy has a 25 to 30% false negative rate when used to diagnose phylloid tumors. Thus, if a solid mass has a benign core biopsy but subsequently grows rapidly or becomes symptomatic, an excisional biopsy is also indicated. The management of fibroadenomas has been debated, and the recommendation changed several times in recent decades. Until the mid-1980s, standard practice was excision of all fibroadenomas. Subsequent studies in the 1980s and 1990s demonstrate the safety of observing the presumed fibroadenoma in women under the age of 35 who had a fine needle aspiration biopsy that didn't contain malignant or suspicious criteria. After that, the question has been asked whether biopsy is even necessary. Smith and Burroughs concluded that patients under the age of 25 with benign ultrasound finding could be safely observed without a biopsy. Management of fibroadenoma entails careful follow-up and reassurance, as most fibroadenomas in adolescence decrease in size and some completely disappears with time. Fibroadenoma less than 3 cm without concerning features can be observed at 1 to 2 month intervals for growth or regression. When the mass regresses, observation at 3 to 4 months interval with increasingly longer interval each time are appropriate for follow-up to 2 years while the mass is regressing. If there is persistence of the lesion, an ultrasound can be obtained. If the ultrasound characteristics are entirely consistent with a fibroadenoma, the mass need not to be biopsied or excised unless there is overriding clinical concern. Cryoablation is an alternative to surgical excision of fibroadenoma, but should only be considered after a core biopsy diagnosis of fibroadenoma has been made. Also, percutaneous Beckham-assisted ultrasound-guided excision is another alternative to open excision technique for removal of fibroadenoma, but may be less effective for lesions more than 2 cm. The American Society of Breast Surgeons recommends the following criteria to establish a patient as a potential candidate for cryoablation or percutaneous excision of a fibroadenoma. The lesion is sonographically visible. The diagnosis of fibroadenoma must be confirmed histologically. Lesion should be less than 4 cm. While the contraindication was core biopsy suggestive of phylloid tumors, poor visualization by ultrasound, core biopsy diagnosis of fibroadenoma while diagnosis is thought to be discordant with finding on imaging or physical examination. Giant fibroadenoma need to be removed whatever the age, because giant fibroadenoma may be misdiagnosed with phylloid tumor. The management of phylloid tumor, surgical management, a complete surgical excision is the standard of care for phylloid tumor. Phylloid tumor should be completely excised because most but not all studies have associated with positive margins with unacceptable high recurrence rate. Positive margins overall occur when phylloid tumors are misdiagnosed as fibroadenoma. The minimum acceptable margin P and clear, however, is controversial and also depends on tumor grade. While they aim for a 1 cm margin for phylloid tumor, the accepted narrower but clear margin for benign but not borderline or malignant phylloid tumors. Mastectomy is generally not indicated for benign phylloid tumor. Negative margin cannot be achieved, and or if the tumor is so large that breast conserving surgery would result in suboptimal cosmetic outcome. Despite best surgical effort, phylloid tumor are known to recur locally with rates that vary with tumor grade. The benign is less than the malignant tumor. The axillary surgery, there is no need for axillary surgery in phylloid tumors. Radiation therapy, when adequate surgical margin cannot be achieved because of tumor location, adjuvant radiation therapy should be administered even after mastectomy. However, when adequate surgical margin can be achieved, there is less agreement about the need for adjuvant radiotherapy. Adjuvant radiotherapy has been shown to reduce local recurrence of borderline or malignant phylloid tumors. In a meta-analysis of 8 observational studies, adjuvant radiotherapy clearly reduced local recurrence of borderline or malignant phylloid tumors after breast-conserving surgery, but had no effect on overall or disease-free survival. The effect of adjuvant radiotherapy in local recurrence after mastectomy was less pronounced. Chemotherapy. Adjuvant chemotherapy should be administered only to a minority of patients whose large tumor, more than 5 centimeters, high risk or recurrent malignant phylloid tumors, and only after a thorough discussion about the risk and benefits of each treatment. Patients with benign or borderline phylloid tumor shouldn't be offered chemotherapy. Hormone therapy. There is no role for hormonal therapy in phylloid tumors. Despite the presence of hormone receptors in the epithelial component of some phylloid tumors, the stromal component is the principal neoplastic cell population responsible for the metastatic behavior, and the expression of the hormone receptors, estrogen receptor beta, is by the stromal cells, not alpha, which is expressed by the epithelial cell. Post-treatment surveillance. Since most recurrence occur in the first 2 years after treatment, history and physical examination every 6 months for the first 2 years, then annually. Patients who have not had mastectomy should resume surveillance with mammography annually. If suspicious lesions are found on mammography or breast examination, further imaging or biopsy may be required. Patients with large tumors more than 5 centimeters or malignant phylloid may need for CT recommendations by the National NCCN guideline of soft tissue sarcoma. Local recurrence. When phylloid tumors recur, they typically recur locally within 2 years of initial excision. Some series have found that the time to local recurrence was shorter for malignant lesions than benign lesions. Although recurrence typically have the same grade as the original tumor, there have been several case reports of benign tumors recurrence as malignant. In one series of 293 phylloid tumors, 6 benign tumors recurred locally as malignant tumors. Recurrent phylloid tumors are treated by surgery or radiation with the goal of avoiding re-recurrence. Resectable recurrence is treated with either re-excision with mild margin or mastectomy, followed by radiotherapy. Unresectable recurrence are treated by palliative irradiation. Metastatic disease has been reported in 13 to 40% of patients with phylloid tumor, and the phylloid tumors metastasize most often to the lung. For patients with metastatic disease, chemotherapy may be administered based on treatment guidelines for soft tissue sarcoma, not the breast cancer. And this diagram summarizes the treatment options for the phylloid tumor. In a summary and recommendation, management of fibroadenoma has been debated and recommendation changed several times in recent decades. The question has been asked whether biopsy is even necessary under the age of 25 with benign ultrasound finding could be safely observed without a biopsy. Reasons to have it to be removed: abnormal biopsy result, pain, or other symptoms, worry or concern about cancer, giant fibroadenoma, older age. Phylloid tumors are uncommon fibroepithelial breast tumor. Breast mass suspicious for phylloid tumor should undergo core biopsy, not fine needle biopsy. For phylloid tumors of the breast, wide excision and at least 1 centimeter safety margin is acceptable. No axillary dissection for phylloid tumors. For borderline or malignant phylloid tumors, adjuvant radiotherapy deliver because it decreases the rate of local recurrence. Adjuvant chemotherapy reserved for highly selected patients with large, high risk or recurrent malignant phylloid tumors. And the most important is the treatment. The chemotherapeutic agent follows a guideline for soft tissue sarcoma, known as breast cancer. No hormonal therapy for phylloid tumors. A history and physical examination every 6 months for 2 years after the initial treatment of phylloid tumors in annually. Patients at high risk of developing the metastatic disease can offer CT and the guidelines for follow-up of soft tissue sarcoma. Local recurrent phylloid tumors that are resectable should undergo wide re-excision followed by adjuvant radiotherapy. Unresectable recurrence are palliated with radiation therapy. Resectable pulmonary metastasis should be resected. Unresectable metastatic phylloid tumor are palliated with chemotherapy according to soft tissue sarcoma guidelines. The majority of patients with benign and borderline phylloids are cured by surgery. The survival rate for malignant phylloid tumors is approximately 60 to 80% per 5 years. Finally, the management of phylloid tumors remain a significant clinical challenge, from diagnosis with a core biopsy to pursuit of an excision margin, and finally in the follow-up regimen employed. The policy of excising all fibroadenomas and that are rapidly growing or more than 3 centimeters in size will ensure that although core biopsy may not always correctly preoperatively identify a phylloid tumor, these tumors will not be missed. Thank you.
Thank you, Professor Walid. Any question, please? Yes. Speaker. Microphone, please.
Thank you, Dr. Walid, for a very explicit presentation about and detailed presentation concerned with cystoma, with phyllodes tumor. وطمن هنا. During your presentation, you suggested that fibroadenomas found in female patients should be observed and not excised. I'm afraid I disagree with that, and I think that any hard lump in the breast should be removed and not left back. And I have to give you an example of a patient I had about 1 month ago who had a fibroadenoma, and the size was about 2.5 centimeters, and when excised, the pathology turned out to be containing a focus of invasive duct carcinoma. So I'm not very much into observing hard breast lumps in female patients. Invasive duct, which phyllodes tumor?
For this, I agree with you, but there is special circumstances in which we can observe. The patient must be young age, less than 25 years, and seen by expert. There is no any suspicious criteria, and followed up within 2 months, then 3 months without any change in the size. But if there is any doubt in this criteria, you should take a biopsy. And in some centers, any fibroadenoma more than 2.5 centimeters should be biopsied by core biopsy and do not find needed, because there is a lot of mistakes or a lot of false negative results by find needed. I agree with you, but this should be, there is criteria for a follow-up, but not for all patients.
Because we are short of time, I'm sorry, so we have to go with the next speaker. And if we have time at the end, we'll give an open discussion. It's a great pleasure to introduce Professor Dr. Reda Dawab. Dr. Reda is the Professor of Surgery at Ain Shams University and one of the pioneers on breast surgery in Ain Shams University and in Egypt. Dr. Reda will be talking about breast picture.